Welcome to the Canadian Breast Cancer Network's webinar for today. Thank you for joining us as we discuss the advancements in care for metastatic breast cancer. I'm Jen Gordon, the Director of Operations with the Canadian Breast Cancer Network. And before we begin our session, I just want to run through a couple quick housekeeping items. We will be taking questions at the end of the presentation today. So Dr. Gelmon will share slides and a full presentation. We'll take questions at the end, but please feel free to submit your questions throughout the presentation. You can use the Q&A tab that's probably at the bottom or the side of your screen. If you're unable to find that, please feel free to submit them through the chat if you can't find the Q&A tab. And then we will get to as many as possible at the end of the session. We also will be recording this session and we'll share the link with you early next week to the recording so that you can review it again or share it with someone who maybe wasn't able to attend. And I will also put a link in the chat where you can access previously recorded webinars and questions and expert sessions hosted by CBCN. And on that note, I'd like to just take a moment to thank our sponsors for today. So our gold sponsor, Viatris, our silver sponsors, Novartis and Merck, our bronze level sponsors, AstraZeneca and Pfizer. So thank you for your support. And on that note, I'd like to welcome the host of our session today, or our co-host for today, actually, who is Kathy Amandalea, is one of our hosts. Kathy is the chair of the board of the Canadian Breast Cancer Network and has personally experienced a breast cancer diagnosis, so really understands how important new therapies and new innovations and new treatments are for the patient community. So Kathy, over to you.
Thanks, Jen. Welcome again, everyone. Thank you for joining us. I'm looking forward to hearing the research and treatment updates that Dr. Gelmon will be sharing with us today. But first, I would like to introduce my co-host for the session, Lise Berube. Welcome, Lise. Lise was initially diagnosed with stage 3 inflammatory breast cancer in 2016 and has been living with metastatic HER2-positive breast cancer since 2018. She has continued to work part-time as a patient safety consultant with Island Health, previously Vancouver Island Health Authority, and spends the rest of her time advocating and volunteering in the cancer community. Welcome, Lise. And joining us as our expert speaker for this session is Dr. Karen Gelmon. Dr. Gelmon is a professor of medicine at the University of British Columbia and medical oncologist at the British Columbia Cancer. So Dr. Gelmon, it's great to see you again and welcome and thank you for joining us, and we wait for your presentation.
Thank you very much. First of all, I have to always thank the CBCN for their support, for allowing me to participate in one of these webinars, and for their great education that they do. I think we all really benefit from their advocacy, from their education, from all that they do. And I'd like to thank all of you for joining us. So we've got Kathy and Lise. I really think this is great that Lise has joined. And I know in the question period, Lisa's experience and views will be very helpful as well. So we're talking today about advancements in the care of metastatic breast cancer. And for some of you who might have heard a previous webinar or who might be very up to date, some of this might be old hat and repetitive, but we can always hear things again. For some of you, some of the science might be a bit over your head, but I think it's important that you hear how we think about things, and then you're able to communicate better with your caregivers, with your friends, with yourself, with anybody, because we all start speaking the same language. These are my conflicts of interest. So let's just talk for a minute about the spectrum of treatment for the patient. We try to have cancer prevention and healthy lifestyle, and although this is very important, we haven't made huge inroads. Obviously, decreasing smoking is important, exercise, good diet is important. There's no one diet that's important. Maintaining a healthy weight, getting good sleep, all of these things are important. We've got cancer screening, and despite controversy, mammograms do work. However, often for young women, they either aren't in the screening time or the screening is less effective for young women, but it's still effective. We have, once their people are diagnosed, cancer treatment, care, delivery. And then we've got very important things such as quality of life, survivorship through to end of life. And when we're talking about advanced cancer, these come up. Through the whole thing, we have to support the patient journey, whether we're healthcare professionals or whether we're friends, family. We have to facilitate prevention, early detection. We really have to encourage research because it's only through research that will improve things. And we have to promote optimal performance. And one of the important things is information and access to information, because that all contributes to the well-being. So these kinds of sessions with information are important. Now, when we talk about cancer care, there's various treatment algorithms, and this might be simplistic, but it's very important to realize that we've got early cancer. That's when a cancer is first diagnosed, when it's localized to the breast or to the breast and to the armpit area. At that point, we try to embark on curative treatment. It's looking at risk versus response, and we try to cure, and hopefully we cure a lot of people, but unfortunately we don't cure everyone, and unfortunately we've just heard Lisa's story of relapsing. When we get advanced cancer, it's still breast cancer, but it's breast cancer that's traveled to other areas. With advanced cancers, what do? We try to improve symptoms. We try to improve survival. And through all that, we want good quality of life. And at some point, sometimes we get to the place where there's no further anti-cancer treatment that are there, but supportive care is very important. Now, supportive care is important through the whole thing, but at some points, supportive care only is what we should be delivering. So when we define the topics, there's the curative part of this curve. There's the non-curative or chronic, and that's when you've got recurrent disease. And then there's the palliative. Now, some people use these terms interchangeably, that if it's treatment that's not curative, it's palliative treatment. And I think we can say that if it's non-curative, it's palliative. But palliative has come to mean really later advanced treatment. Palliative is too, not end of life care. I think with our new treatments that often allow people to live very productive lives, albeit with ongoing cancer concerns, but productive lives during this time, talking about non-curative or chronic is important. Having said that, chronic advanced breast cancer is not the same as chronic arthritis or chronic diabetes, because there's always the cloud hanging over your head of when is this cancer going to progress, and there's usually treatment hanging over your head. But thinking about it like this, now just to remind you, I know this sounds simple, but this is all still breast cancer. Breast cancers are made up of millions and millions of cells. And when there's just disease in the breast or disease in the lymph nodes, we know there are often cells that have escaped. So despite the best treatment here, and our treatments are improving, sometimes those cancer cells can come back. And when those cancer cells can come back, it becomes advanced or metastatic or stage 4 breast cancer. Those three terms are all the same. And in that situation, we're trying to treat people to maintain quality of life to the best of our ability with treatments that are effective, that are as least toxic as possible, that are convenient for the patients, and that are funded. And what we're going to be talking about today is new treatments for that advanced breast cancer. Now, how do we measure success? What's important to realize is there's all these terms that we use as oncologists, some of which are intuitive and make sense, and some of which don't. We also have to realize that success might be different for different people. So success to the oncologist, we talk about progression-free survival. What does that mean in advanced cancer? It means how long does the person live with that treatment from the time the treatment started for their advanced disease till it's progressing. We talk about, overall survival, which is overall survival is how long does a person live? We talk about response rate. That means, does the cancer shrink? How long is the treatment effective? So if somebody's on a treatment for their advanced cancer, how long is that effective? That's a duration. And we worry about access to appropriate therapy. A family doctor, who's an important member of the team, is important in terms of supporting the patient. And a family doctor could also be a nurse practitioner, could be a pharmacist, it could be a physio, it could be any other health practitioner. And I'm sorry, I had it as health practitioner. I don't know what happened there. But what all of those health practitioners want to do is support good quality survival with little or no toxicity. And what everyone wants to have is clear outcome goals to know, why are we giving this treatment? And it's important that we have good communication and know why we're giving it. What about to the patient? And you as patients or as friends or whatever know this. Success to the patient is feeling better, having a decrease in the symptoms, having an improvement in quality of life. Increased duration of survival, so having a longer survival if it's a good survival with good quality of life. You know, some people maybe want to survive being bedridden, but most people want to feel like they're having a good quality of life so they can be around their friends or their family or their kids or their partner or their job or just noticing a beautiful day. So they want some ability to have some good quality of life. And how they define good quality of life is very personal. So to somebody who's perfectly well, good quality of life might be able to exercise every day. For somebody who's got more symptoms or more disease, good quality of life might just be being out of pain. And it's not up to any of us to define what someone's good quality of life is. They want a treatment with few side effects. They want hope and continued options. And they want to feel safe, respected, and make sure that their family or friends feel safe. And how can we make people feel safe? I think one of the ways is through education, through truthfulness, through communication, through having these sorts of opportunities to speak about things. What's important is to know that cancers are all different, and so are individuals. So we have different kinds of cancer, and we're going to be talking about this, but there's also individual, what we call heterogeneity. So people might respond to things differently. They might respond to treatments differently. One person getting vomiting and one person not. One person being tired, one person being not. They might respond to a diagnosis of cancer differently. One person wanting to talk about, one person not. One person wanting to keep working and one person not. And we have to realize that advanced breast cancer is no exception to individual heterogeneity. I always tell patients that, it's a little bit like periods. Some people get their periods and nobody ever notices, they don't notice, and other people are bedridden. We're all different how we deal with things, and we have to respect that. We also have to know that there's not one treatment. So people often say, I was sitting in the waiting room and I was talking to, they say to me, I was talking to another patient of yours, and he or she is getting that treatment and I'm getting this treatment. Why? And one of the things to realize is that treatment of advanced cancer is not a black and white situation. Let's just talk for a minute about treatment of early cancer, just to put it into context. So as I said, it's for cure. Usually we have multidisciplinary care, so surgeons, radiation oncologists, medical oncologists, pharmacists, nurses. The providers might depend on the type of cancer, age of patient, comorbidities. There might be a cardiologist in there. Surgery is part of it. Chemotherapy may be part of it. Specific therapies might be part of it, such as HER2 treatment, triple negative immunotherapy, PARP inhibitors. Sorry, PARP spelled wrong. If they're hormone sensitive, hormone agents, and radiation might be part of it. All of these things are to deal with trying to cure the patient. So as I said, cancers are made up of millions and millions of cells. There might be a lump in the breast, but we worry that there could be cells that have escaped. We try to estimate and determine if cells have escaped, but in 2022, we can't always do that. And therefore, we treat for the idea of cure. If someone has a teeny cancer that's a low risk, they might only need some hormones. They might not need radiation. They might just need surgery. If someone's got a bigger cancer that's a higher risk cancer, they might need chemo, immunotherapy, radiation, surgery, the whole bit. So it depends on a number of different things. It's balancing the risk of relapse and the response to treatment. So we try to estimate what's the risk of this cancer relapsing and causing death, and what's the response going to be with treatment. Now, what about advanced cancer? So advanced cancer, as I said, is also known as stage 4, is also known as metastatic cancer. What we try to do is improve the outcome, make people live longer with good quality of life. And we've had a number of different new treatments I'm going to talk about that have really improved it. The old thing used to be that people, once they had a diagnosis of advanced cancer, lived anywhere from 18 to 24 months as an average. Some people, unfortunately, still do live that. Some people live shorter. But for very, very many people, they can live longer. They can keep having reasonably good quality of life. And our goal is to cure patients with advanced cancer. But if we can't cure them, then our goal is to have them live longer and good lives. And as I said, there's been significant survival for HER2 positive, ER positives, and now for triple negative, although there's less improvement for triple negative. However, some advanced cancers remain very resistant, and it's incurable for all but a small minority, so we need new treatments. About 5% of breast cancers in the past were cured with advanced disease. That's going up a little bit, but it's still too small. So as I said, it's good quality of life, not just prolongation. There's issues of toxicity and benefit. Treatments must be effective, tolerable, providing survival benefit if possible, good quality of life, and toxicity must be manageable. And we'll talk a bit about that. Now, we know there are different kinds of breast cancer. And if you read the literature, the science literature, there's more and more and more kinds. But usually what we talk about is that there's estrogen receptor positive, HER2 negative, estrogen receptor negative, HER2 negative, which we call triple negative, estrogen receptor positive, HER2 positive, and ER negative, HER2 negative. Sorry, this is ER positive, HER2 positive. So there's different kinds. And so there's HER2 related, there's triple negatives, there's luminal A and luminal B. These are something called circus plots. So what you can see is this circus plot is pretty empty and it gets more and more full. This is the luminal A, ER positive, PR positive. They're the slowest growing cancers and they have the fewest mutations. Mutations are changes in the DNA of the tumor, and you can see there's very few. You can see luminal B, which are also ER positive, HER2 negative, have a few more mutations, HER2 positive more and triple negative more again. So you can see that there's more complexity, they're less like normal cells, and this is providing us with some options to understand these cancers. This is another way to look at it. So here are the ER positive, HER2 negative, the luminal. These are the luminal A, the pink. The magenta is the HER2 positive. This is ER negative, HER2 positive, and then these are the triple negative. This is how we look at it just in the clinic. About 15, 20 years ago, we started looking at luminal A and luminal B, understanding these are different, even though they're both ER positives. But you can see that the HER2 and the triple negative stayed the same. Over the last decade, we've been able to divide up these ER positives more and more, and we're starting to divide up the triple negative. But you can see we still aren't dividing up the HER2 positives, and we're starting to get there. In December at our San Antonio meeting, we are starting to get there, but we're not there yet. Why is this important? This is important because if we understand all these different kinds of breast cancer, we can start treating them differently, and we might be able to treat them more effectively. What's another way of looking at it? Again, here's the HER2 positive, the hormone positive, triple negative. And what you can see here are what we call different biomarkers or different targets. So PI3 kinase is in both the HER2 positive as well as here you can see the ER positive. And we now have drugs for PI3 kinase. PD-L1 is an immune marker, and you can see it's in the HER2 positive and in the triple negative. And we now have drugs for that. HER2 we've got, and we know that there's HER2 low as well as HER2 positive. And ESR1 is a mutation that causes people to be resistant to hormone treatment. And now we're looking at that. So what does this lead to? By dividing it up like this, we can start defining what treatments might be important. And very soon, there's going to be more and more things in this kind of list. But just so you know, this is where we're going. We're going from these simple definitions to a more complicated definition that's related to treatments that might be effective. So we heard from Lise that she was HER2 positive, and we're going to hear more. So she got anti-HER2 treatment. And there are other things coming along that might be effective. Here's the way we can look at it. ER positive often have long disease-free survivals, few symptoms, and endocrine therapy is important. And we now also have things called Cdk46 inhibitors and PI3 kinase inhibitors. We're going to talk about that. HER2, we've got lots of new anti-HER2 treatments coming along. For ER negative or ER positive, PR negative, rapidly progressive, they might become refractory to hormone treatment. So we have chemotherapy. If people have inherited mutations in their BRCA, we have PARP inhibitors, and now we have immunotherapy. And bone metastases, cancer going to bone is common in breast cancer, advanced breast cancer. We've got drugs for that. So we've got a number of different things out there that we can use. Now, how do we decide what to do? Oops, I need to go back here. What we do is we look at a number of things. So we often biopsy the recurrence in advanced cancer to find out if it's the same as what was the primary. So a lot of people get a diagnosis of advanced cancer. Their scan shows something. They've got bone pain and they've got shortness of breath. They get a CT scan and there's disease there, and they say, and the doctor says, well, we want a biopsy. And they think, why do you need to put me through a biopsy? But often it's important to get a biopsy to know, is it the same as the initial cancer? We want to look at how long have they been well. Did they get diagnosed less than a year ago or 10 years ago? Because that might make a difference in how fast is their cancer growing and will they respond to treatments they already had in the adjuvant setting. We want to know how well they are. Something called performance status just means how well are they? How many treatments have they? Have they had prior responses? And all of those things are important. We also have to know that one metastasis can happen and then it can also seed another metastasis. And all metastases are not the same. So you may have somebody with a breast cancer, then it might seed into the liver. And then from the liver, it could seed into the bone or the lung or the brain. And those might be different. And what we're learning over time is that we need to understand how these might change. We used to think that they'd all respond exactly the same. And the majority of times, like 80% of the time they do, but not always. Sometimes they respond differently. So we need to understand more about how does cancer evolve? How does it change over time? For estrogen receptor positive cancer, which we're going to talk about first, 70% of breast cancers are what we call hormone responsive. What does that mean? Whether we're premenopausal or postmenopausal, we always have estrogen in our bodies, and men have some hormone and estrogens in their bodies as well. We know that about 70% of breast cancers have what we call receptors on it. So what is that? On the outside of the membrane, they've got these little doors that open when estrogen comes. The estrogen comes into the cell and it turns on the cell to divide. Before menopause, we make estrogen in our ovaries. After menopause, we make estrogen in our tissues. We used to just give hormones like tamoxifen or letrozole or anastrozole or exemestane. In the last decade, we've discovered these things called Cdk46 inhibitors. And what do? They work with the anti-estrogen drug to block the cell from dividing. So they're given with either letrozole or an aromatase inhibitor, or sometimes a drug called fulvestrant, which is a cousin of tamoxifen. And we know that the two together can block the cell going into cycles. So they're given with an aromatase inhibitor. We also have new drugs called PI3 kinase mutations. One's called alpelisib, and it's given sometimes for those 40% of patients with ER-positive disease who have this mutation. So when we start talking about precision medicine means knowing what are the biomarkers on that cancer. And you might remember that slide I showed you with all those different targets. PI3 kinase is found in both HER2-positive and ER-positive. It's the most common mutation in breast cancer, and we now have some drugs that target that. We also have chemotherapy drugs like oral capecitabine or chemo. So the standard of care for ER-positive breast cancers, hormone-positive breast cancers, is to start often with a CDK inhibitor. Often if they're PI3 kinase mutation, to go there. Second line means the treatment you give after the first treatment quits working. And unfortunately, most of our treatments quit working after time, but our goal is to have them work for as long as possible. And then there's other options afterwards. What's exciting about this area is for years, we didn't have any good survival benefit in ER-positive. And those are the patients where we used to talk about 18 to 24 months and nothing changing. But in the last few years, there have been all of these studies that have been published in very good journals like our New England Journal of Medicine that have shown that we've improved the good quality survival for patients with hormone-positive advanced breast cancer. For somebody like me who's been in practice, this has been exciting. For patients, this is both exciting and important. And for families and for our world, this is important. So let's just talk about the Cdk46 inhibitor. There have been lots of trials, and there are 3 different Cdk46 inhibitors. And I'm going to use their names that we use. These aren't the trade names, but one of them is palbociclib, also known as Embrance. One of them is ribociclib. One of them is abemaciclib. And all of these have been used in what we call first-line treatment, the first line of treatment. They've also been studied in second and later lines, and they've been shown to be effective when given with a hormone treatment in decreasing the risk of the cancer progressing. I'm going to show you just one study, the Mona Lisa 2 study, which randomized postmenopausal women, although there are studies like Mona Lisa 7 that included premenopausal women, and some of these studies also included men, and these drugs are now licensed for premenopausal, postmenopausal women and men. But this study just enrolled postmenopausal women with hormone-positive, HER2-negative advanced breast cancer who hadn't had any prior therapy for their advanced disease, but they could have had prior therapy for early disease. 668 women were given either ribociclib plus their letrozole, standard hormone treatment, or a placebo plus letrozole. And the primary endpoint, as I talked about earlier, was progression-free survival. How long from the time they started this treatment did their cancer stay controlled? And they also looked at overall survival. These were the results that were recently reported and published. And what was exciting was the addition of ribociclib to the letrozole caused a significant survival benefit. As I said, there are 3 CDK4/6 inhibitors, and I'm just showing you one of them right now. What was exciting was the median survival. So median means right in the middle. There are half survived shorter time, half survived a longer time. But the median overall survival was 63.9 months, 64 months. If you think back that I was saying the median survival used to be 18 to 24 months, that's great. Now, obviously, that's only a little over 5 years. For many women, they'd say, I don't want to just live 5 years. I want to live 10, 20, 30 years. I want to see my grandchildren, my great-grandchildren. But for somebody with advanced disease, and certainly for us in the field, a median survival of over 5 years is so much better than we used to see. And it suggests that we could keep doing better and better. So that's exciting. What's also exciting is even the survival in those that got just letrozole is better than it used to be. What's also important is it didn't just happen at the beginning. The survival of patients receiving this combination increased over time. So at 72 months, which you realize is 6 years, you can see that there were 44% of people compared to 32% of people. So this is an advance. So first-line treatment in advanced endocrine positive disease is now based on these kinds of survival results, looking at a CDK4/6 inhibitor. If people are responding to hormone therapy, then they can delay getting chemo, and nobody likes going on chemo. And this trial also showed that you could delay getting chemo. Now, what about, is this better than chemotherapy? And this PEARL study randomized patients to either get chemotherapy with capecitabine or to get the palbociclib, the other CDK4/6 inhibitor, and it showed there was no difference. So people can keep getting a CDK4/6 and a hormone rather than going to chemo, which is good. Let's move on and talk about HER2-positive disease. HER2-positive disease affects about 15% of breast cancers. Why do we call it HER2-positive? When we look at this breast cancer, and these are pictures of a breast cancer slide, this is what the pathologist sees when they look. They stain it with something that goes to the membrane of the cell and shows up the HER2. And if it goes brown like this, it's HER2-positive, meaning that there's too much HER2. HER2-positive cancers were first described in the late 1980s and were known as more aggressive cancers, but we've now got good treatments. What we also know about HER2-positive cancers is they've got too much or too many copies of that gene, and that's what the Isher fish is called. And the Isher fish shows too many dots. There are too many copies. So this sort of revs up the cancer, makes it grow more. We also know that it's got more immune cells in the HER2. And there's also something called HER2 mutations, but that's something different. We've had Herceptin and we've had Perjeta for a long time. A few years ago, there was this study that was published. And this study took patients with advanced HER2-positive cancer, all of whom had had Herceptin, pertuzumab, and T-DM1. So they'd all had these drugs, which are standard drugs. And I was lucky to be on the steering committee I was part of developing this trial. As you've heard from Lise, unfortunately, HER2-positive cancers like to go to the brain, and at least 50% of people with advanced HER2-positive cancers end up getting disease in their brain, and the disease in the brain can be quite devastating. Most trials didn't allow people with progressive brain disease in, but this trial allowed people with previous brain metastases, untreated brain metastases, progressing brain metastases, or no brain metastases in. And they randomized people in a 2-to-1, so twice as many people got this than this, to receive Herceptin and capecitabine, 2 common agents, either with tucatinib, another oral drug, or without tucatinib with a placebo. The way to do good science, unfortunately, is to use a placebo, because then you can get a good comparison. What this showed was that there was an improvement in progression-free survival and in overall survival for those patients that got the tucatinib. And this included everyone as well as those people with brain mets. This was very exciting because this was third-line treatment. And a lot of people didn't think you got much success after a couple lines of treatment. This was very exciting because these patients, many of them had brain metastases. And to show this benefit was important. Tucatinib is now licensed in Canada and is variably available, but hopefully is becoming more available for patients. This paper was published in the New England Journal, and you'll recognize a few Canadian names like Phil Bedard and myself and others who were involved in this trial. Now, after tucatinib, there was another drug coming along, and this trial was published, something called Destiny-01. And this trial took people, again, who had HER2-positive cancers, and these patients had had multiple treatments, lots of treatments. They were first just looking at what's the right dose to give for this. And what they found out was that this dose of 5.4 was the right dose. What they showed that was exciting is that tumors shrunk. Again, these were people who'd had lots and lots of treatment. So to see that these treatments shrunk was amazing. So this is something we call a waterfall plot. This is 0. These are cancers that grew. So you can see some cancers grew after they got this, but these are cancers that shrunk. What we like to see is cancers shrinking at least 30%. And this line is a 30%. So you can see that although some cancers shrunk less than 30%, lots of cancers shrunk more than 30%. And there were 11 patients who had disappearance of all their disease despite lots of other treatment. Now that's not going to stay away forever maybe, but it shrunk a lot. So they had 61% almost of patients who had been multiply pretreated have their cancer shrink with this. Everybody was really excited. So the next question with this new drug called T-DXd was, well, what about, how does it compare to our standard treatment? Our standard treatment for second-line treatment was T-DM1. So this study had people looking at T-DXd versus T-DM1. What are these drugs? These are drugs that we call drug conjugates. So what they have is they have Herceptin on it, they've got a chemotherapy on it, and they've got something called a release. That means that the chemo is released to the cancer cell. So the Herceptin part gloms onto the cancer cell that's HER2 positive. This release releases the chemo to that cancer cell. And this study, the Destiny-03, showed that the T-DXd was way better than the T-DM1. You can see this difference. 12-month progression-free survival, 76% almost of patients on the T-DXd were well at 12 months, versus only 34 people on T-DM1, which had been our previous standard. And it was important. It was important in everyone, whether they were estrogen positive, whether they had brain mets, whether they had liver mets, everyone benefited. Again, here's the tumors shrinking, these waterfall plots. So the response rate here was almost 97% for those who got the T-DXd versus only about 77% for TDM1. So we had thought 77% was great for TDM1, and it was, but it isn't as good as we could do. Now, early on, I was talking about toxicity. All of these drugs have toxicity, unfortunately. Some drugs have less toxicity than others. The new drug I talked about, tucatinib, causes diarrhea. The Cdk46 inhibitors often cause white counts to go down or sore mouths. T-DXd unfortunately has a very severe potential toxicity, something called pneumonitis or ILD, inflammation of the lung, difficulty breathing. If it's just a little bit, what we would call grade 1, it's not very severe. But if it goes up here, people can't breathe. It can be very severe. And unfortunately, this drug can cause pneumonitis. If it's picked up early and the drug is stopped and the dose is decreased, the drug can be continued. But if it's picked up later, it's dangerous. So this is something we have to learn with this drug. How do we pick up this ILD early? So there's always a credit-debit balance. What's the benefit and what's the side effects? For any grade was 10.5%. For high grade was 7.8%. So this is the problem. So it's an effective drug, but it's got a potential serious toxicity. So how do we treat people with HER2-positive cancer? In 2021, we changed from giving pertuzumab first and TDM1 to thinking about tucatinib. And now in 2022, we're hoping, and this is what we're trying to get approved by the funding agency in the next few weeks, we're hoping to get this drug, T-DXd or HER2, approved soon for patients with HER2-positive disease. I'm going to finish up just talking about immune. Immune treatments are very exciting, and immune treatments have come along and have been very, very important in some diseases like melanoma. In breast cancer, we've had less success, but in triple-negative breast cancer, we're now starting to see success with immune. Immune treatments are mainly what we call PD-L1 or PDL or PD-1 treatments. Now, what is it? What happens is cancer cells can evade the immune system. So the immune system is very complex. It's not as simple as just the RCMP running around your body getting their man. It's a very complex system where there's some stuff in the blood, there's some cells. The immune system is trying to protect your body from foreign things like cancers. What cancers can do, though, is they can put up masks. And those masks can mean that the immune system can't see the cancer cell. And if the immune system can't see the cancer cell, then it can't destroy it. What the PD-L1 inhibitors do is they take away those masks. So by taking away those masks, they can have the chemo and the immune system work better. And so that's what we try to do with these immune drugs. There have been 3 big trials with giving chemo plus immune inhibitors in advanced breast cancer that's triple negative. One of them was called Impassion 131, Impassion 130, and Keynote 355. These were with a drug called atezo and paclitaxel. These were with either paclitaxel or Abraxane or gemcitabine carbo plus pembro. What you can see is that there was a survival benefit for 2 of them. And I'm just going to talk about one of them. One of them, which we call Keynote 355, randomized patients with triple negative cancer to either receive the pembro plus chemo or placebo plus chemo. And here's our friend progressive disease as the endpoint. What one can see is that for those patients whose tumor had expression of immune markers, something called their CPS score, there was a 4-month difference if they got the pembro. Whereas those patients who didn't have as much immune marker had only about a 2-month difference. So for those patients whose cancers were immune sensitive, the addition of an immune treatment to the chemo made a big difference. And this is exciting, and this has now been approved in Canada and needs to get funded. So it's still chemo, And it's only for some of the patients, but it's a step ahead. The duration of response was about 12 months, almost 13 months in this group versus 7 months. It wasn't as long in the people without the immune markers. Again, there are side effects. Many people have thyroid dysfunction or pneumonitis inflammation or colitis inflammation of the bowel, diarrhea or shortness of breath, but those can be dealt with. There's also a keynote study that I'm just going to draw your attention to, giving the same drug pembro to triple negative cancers in the early setting. And this has shown a benefit too. And we're trying to get this approved in Canada as well, because we think that we can cure more women with triple negative breast cancer in the early setting if we use this combination. So pembro for triple negative in Canada right now, there's data for the first line metastatic, but you need to test the tumors to see if they got this immune marker. And there's now data in early cancer too. There's two things I want to talk about finally. About 10% of breast cancer patients have what genes that they've inherited for their mother or father that put them at higher risk of getting a cancer. Two of these genes are the BRCA1 or BRCA2 proteins that account for about 5 or 6% right now, but with more testing, I suspect it'll double. When you have one of these problems of the inherited defective BRCA, you can't repair your DNA as well. So you're at a higher risk of getting cancer. We know that BRCA1 are often triple negative cancers and often occur at a young age. BRCA2 often are hormone positive and slightly older, and often there's ovarian cancer with either of them. And with BRCA2 and BRCA1, sometimes pancreatic cancer, melanomas, and in men with BRCA2, prostate cancer. There's a drug called olaparib, which has shown to be of value in those patients with these germline mutations who had advanced breast cancer, whether they're hormone positive or hormone negative. It was only a 3-month difference compared to chemotherapy. This drug has now also shown a benefit in early disease and is right now at Health Canada trying to get approved. There are also other germline mutations, including one called PALB2. And for those patients, it also looks like olaparib is important. Whereas for other patients with other mutations, one called AT and one called CHEK2, it's not effective. Triple negative cancer is also often a scary thing. And there's lots of different kinds of triple negative cancers. So some of them respond really well to chemo. Some of them, if they've got germline, might be a PARP inhibitor. Some of them have immunotherapy. But there are new drugs coming along. And one of those new drugs is known as sacituzumab govitecan or Trodelvy. And this looks a lot like that TDXD I showed you. So it's got an antibody and it's got a chemo with it. These are the new drug conjugates that we're using. And this one, called Trodelvy, has been shown to be of advantage in triple negative cancers that have been previously treated. This drug is also getting approved and is available on compassionate release, although there's a very limited supply, but it's new hope for patients with triple negative cancers. So in summary, estrogen positive cancers, there's a role for targeted therapies with Cdk46, and there's real improvements. For HER2 positives, we've got standard therapies like Herceptin and Perjeta, but we've got some exciting new treatments. For triple negative, immunotherapy has a role with chemo, and hopefully that'll be widely available soon. And we've got some new agents. And for those patients with germline mutations, we've got PARP inhibitors, and those are now being combined with immune agents. I want to finish up by just talking about a couple other things. So what are the new directions? We have to understand why some cancers don't respond. We have to understand when to use these new drugs. We have to also learn how to detect residual cancer soon. And there's something called oligomets. So oligomets is when there's just 1 or 2 or 3 metastases. And there's a lot of work going on right now. And actually one of the international leaders in this oligomets, David De Palma, is in London, Ontario. And we're starting to look at whether we can aggressively treat these oligomets and make a difference. Just to think about this, in the 1960s, we used to not be able to detect anything early. Now, if we do PET scans, we can detect earlier. But PET scans have radiation. So how many times do we want to do PET scans? Not necessarily that many times. But there's now a suggestion that there's minimal residual disease that we could maybe detect. So here's somebody with a new clinical diagnosis. They get surgery and chemo. Their cancer goes down to here, and they might not get recurrence and have symptoms till here. But is there a way we could detect these cancers earlier? And would that make a difference? I have to tell you that right now we don't know if it would make a difference. But this is one of the new directions. And what the CBCN titled this as is new directions. So I want to talk about new directions. So how are we going to define that? There's something called circulating tumor DNA where we can take a blood test and we can look and see if there's any tumor DNA in your body. This is not ready for prime time yet, but there's a lot of studies going on. And my colleague Sam Aparicio and I are just submitting a paper where we looked at patients with triple negative cancer who had neoadjuvant treatment and then had surgery, and we followed them along to see if we can detect that their cancer is going to come back earlier. Now, it only makes sense to detect it earlier if you can do something about it. But the question will be if we can detect that earlier and we can give effective treatment based on their biomarkers, will we be able to cure more people and not have people relapse? And this would be the same with HER2-positive or ER-positive cancers that are high risk. So this isn't ready for prime time. Don't spend thousands of dollars getting your circulating tumor DNA done yet. There are ways you can get it done, but don't spend it yet. But it's the future, I think. Finally, although we're increasing the survival of persons with advanced cancer, we also have to integrate supportive care and end-of-life care. For anyone with advanced cancer, you just have to start talking about this, because if you don't talk about it, it's kind of the elephant in the cage. And for kids, for partners, for yourself, you need to talk about it. You hope that things are going to go well, but you don't know. And communication and multidisciplinary care are key. So we always have hope. As oncologists, we want to support hope. We want, as patients, you want to have hope that we can be improving. But the hope may also be about controlling pain and other symptoms. And hope can also just be about being there. The reality is we have to provide a balance between living your life the best way and being honest with you about what we have to offer. So although these are hard conversations, they're important conversations to have. And what I always talk to my patients about is if you have that conversation, you don't have to have it over and over again, but you've had it. So you have to discuss the details of dying, where you want to die, and what are the issues for the patient and family. And if you don't have to put those into action for 20 years, great. But even those of us without cancer should be talking about this. Communication is important, and balancing the need to know what's truthful. How do you accept the uncertainty? How do you live with advanced breast cancer, not knowing what's going to happen next year? Where are you going to be? You live by doing short-term goals and long-term goals, and all of us actually should be doing that. We support all the symptoms of advanced disease, and that's important, whether it's pain, shortness of breath, nausea, fatigue, or the psychological things of uncertainty, anxiety, and depression. So in summary, outcomes have improved remarkably. The majority of breast cancer patients are cured now. However, there are too many persons relapsing and dying, and we really need new interventions for prevention, diagnosis, treatment, and survival. And I want to thank you for your attention, and I'm sorry if some of this was too scientific, but I wanted to get those in so you could know how we think. Thank you.
Thank you very much. That was incredibly informative, Dr. Gelmon. I mean, I was writing down questions, and anytime I wrote it down, you had an answer to it before I could even ask you at the end of the your presentation. One of which was, the topic of risk of relapse. With the psychological component that goes along with the diagnoses. And yes, women go through years without relapse, whether it be from early diagnoses or, first diagnoses, and then women who, metastasize and they still have, a good quality of life for an extended period with all the drugs that you've described. Will there ever be a time where you could use the word cure without them? You say yes? You say yes?
You have to be able. So just one of the things that I didn't put in, but cancers are different. So An estrogen receptor positive cancer right now can relapse over a long period of time. It can relapse at, 50% of the relapses are usually within the first 5 years, but I've had patients 20 years later who relapse, unfortunately. So with estrogen receptor positive cancers, sometimes it's hard. With triple negative cancers, though, if they're going to relapse, they usually relapse within the first 4.5 years. If a triple negative cancer hasn't relapsed within the first 4.5, 5 years, it's very, very unlikely. There's a couple percent risk only of it relapsing. Somebody could get a new cancer. Somebody particularly with a germline mutation might get a new cancer. But yeah, I sometimes say, yeah, people can be cured. With a HER2 positive cancer, it's a bit variable. HER2 positive, ER negative, they usually relapse within the first 5 years. HER2 positive, ER positive can relapse later. What about with advanced cancer? I have a handful of patients in my practice who I would say are cured. I have one patient who hasn't had any treatment for her triple negative breast cancer since 2007. I have another patient with a BRCA1 mutation who had a quick relapse in her liver in the 1990s and hasn't had anything else in her liver since then. She got another breast cancer because she didn't want to get her breasts off, but it was treated, and that was about 8 years ago, and she's fine. I have another patient who had disease in her lungs about 20 years ago who doesn't have anything. She was a HER2 positive breast cancer. It's a handful of patients only, and that's the problem. So I think we do have some patients who are cured, but it's not everyone. The other thing to say is, right now it's hard to do it, but maybe things like the circulating tumor DNA are going to allow us to have more scientific way. Right now it's a bit like buying a house. You bought at the low price only when you look back. When somebody is 20 years out from their diagnosis, we maybe can say they're cured. But maybe we'll have a more scientific way to look and say that. And I'm hoping that, because I do think for anyone with a diagnosis of cancer, the uncertainty is the hardest thing.
Yes, absolutely. And that's why I asked the question. One other thing that came to mind was under your presentation on breast classification. So the features of the tumor, they keep, you keep adding more names to these features as time has gone by, right? How much more do you think you will see in terms of new features of breast cancer?
I think we're going to find more and more and more features. So there's two different things. So talking about precision medicine, which is something near and dear to you guys, precision medicine has to talk about the tumor. So we have to know about the tumor. And there's going to be mutations, like I've talked about PI3K mutations that are 40%. But there's also some cancers that evolve over time and change, and some cancers that don't. So we're going to learn more about not just the mutations, but which cancers are the changeable ones. It's a little bit like we all have friends who 1 week are blonde, the next week are redhead, the next week are brunette. We have other friends who are blonde their entire time until they're gray. So, who are the evolving cancers that are changing their hair color all the time? And who are the cancers that just sit there? The final thing about precision medicine is the individual. How do I metabolize a drug versus how do you, Kathy, versus how does Lisa metabolize a drug? We all metabolize drugs differently. So those drugs might act differently. So Herceptin in me might act differently than Herceptin in Lisa, which might be different than Kathy. So I think we're going to learn more and more about the tumor, more and more about the host.
Great. And I hope research continues to do this. And with your good help, I think we're going to move it along. So I'm going to turn it over to Lise, who I'm sure has a couple of questions that she could ask Dr. Gelmon.
Thanks, Kathy, and thank you, Dr. Gelmon. That's actually a perfect sequence over to the question that I wanted to touch on a bit, which is exactly around personalized oncogenetics. And you spoke a lot about, identifying different characteristics of the tumor to be able to personalize medicine and the personalized approach to medicine. And I'm just curious a bit more. I know that we're kind of across Canada, so it might be different province-wise, but I'm curious about what advances are being done, what kind of funding is being provided, if this is information that you have in regards to more personalized treatments. And I know we're hearing a lot about that being kind of the future of cancer care. And I know in BC, we're both in BC, but I know we have the POG program that is very, very limited, and I've been denied several times. And I'm curious of kind of what is in the works as far as moving that forward to be able to identify the characteristics to provide that care.
So Lisa, I think you've touched on something that's really important. One of the things is that we've got two different kinds of testing. We've got research testing where scientists are doing very complicated, interesting work. And then we've got service pathology, where pathologists in hospitals or cancer clinics and that are looking at the cancers. And those things aren't joined. Now, in some other cancers, like lung cancer, they found some targets in the lab that they very quickly moved into the clinic. And they've got treatments now that sort of have that melded. In breast cancer, in the 1990s, we started doing estrogen, and then we started doing HER2. And what hasn't happened in breast cancer yet is those two, research and service, come together in a good way. And we really need to start doing that. Now, it hasn't come together for a few reasons. One of the reasons is that there haven't been as many good targets that really change treatment yet. One of the reasons is that there haven't been too many drugs there that you could use if you identified those treatments. So it's a bit of those things. If there's not the need, you don't get it. Like if nobody's wearing shoes, you don't have a shoe store on the street. So part of the reason it hasn't been come into mainstream service pathology is there hasn't been the need, but we need to catch up. We need to catch up right across Canada. Some places are doing better than others. The setup right now in Quebec is great. There's much more setup of service and lab interchange than there was. Ontario is coming on. Lots of places are coming on, but we've got to get that happening more quickly so that breast cancers can be identified with their markers more efficiently. The second thing is we have to have more successful markers. So that slide I showed you going into the different markers, we have to have more successful markers. Now, what's interesting is you don't always need a marker. The new drug Trodelvy for triple negative cancers, we don't need a marker. It works in most triple negative cancers. So not all cancers, not all drugs need a marker. So we're getting there, but what we have to be able to do is move the research into the service more quickly. We have to be able to say to somebody right at their diagnosis early on, your triple negative cancer is this kind of triple negative. You have a BRCA mutation or something. The other places I talked about was HER2-positive cancers. We haven't defined those enough, but we need to. Recently, one of the Cdk46 inhibitors is getting approval for early breast cancer with something as simple as something called the Ki67. The Ki67 is just a marker that can be done in a pathology lab looking at how fast is the cancer growing. That needs to go into labs across Canada now so that the women who have high Ki67s can get the drug abemaciclib or Verenzia. So I think what we have to really, really work at, and the CBCN can be important in this, is getting any of those markers that are going to be helpful to persons with breast cancer out of the research lab and into the service lab now. Does that help?
Yeah, very much. Thanks. It helps to put it into context and kind of understand how the interchanges between the systems work.
Great. I'm going to ask a question from somebody who submitted a question. So how do you go about looking at person's individual biomarkers? What's the process for that?
So that's a good question. So the process for that is a bit what we were talking about. It needs to be more standardized. So it needs to be more standardized that your tumor is looked at right away. Some markers are in the tumor right from the first tumor that you had. Some markers are only in the relapse tumor, which is why we talked about rebiopsy. And there are some areas that are harder to biopsy than others, like bone is harder to biopsy than liver or the nodes or something like that. Sometimes we don't biopsy if it's not going to change treatment, but we usually want to get a biopsy. So how do we identify? It depends on what we're looking for. The first thing to do is to look, is it still ER positive, ER negative? Is it PR positive, PR negative? Is it HER2 positive, HER2 negative? The second thing to look at are markers like PI3 kinase, which might make a difference in terms of treatment. The third thing in an immune, like in triple negative cancer, might be to look at, does it have the PD-L1 CPS score? How do we look at the CPS score? Are people? So how that's done is differently across Canada. And the oncologist that somebody's seeing is going to try to get that done if it's going to change therapy. That's what's important. Sometimes things are done on clinical trials. So some persons are put on clinical trials and their tumor is accessed. There are some, Lise mentioned the POG program. There are programs all across Canada. So the Octane program in Ontario or other programs where they're looking to sequence the tumor and look for changes in the tumor that might lead to how to treat a patient. So partly it depends on where you are, partly it depends on what your tumor is, partly it depends on what stage. With an ER-positive cancer right now, if you've got diagnosis of relapse cancer, the Cdk46 inhibitors plus hormones look like they're very, very effective. So most people will go on that if they're still ER-positive. And if they respond to that, they can have 5-6 years of good response with that. There's no sense doing the markers on the tumor right at the beginning because it might evolve. It might change in 5-6 years. So the time to look at it often is when the cancer is growing. You would also look at it if it's going to make a difference in terms of what treatment you do. So there's a whole lot of questions. You know, it's a great question. How do you look at a person's individual biomarkers? You look at them by looking at the tumor. You look at the primary tumor and the metastatic or recurrent tumor. And you look at what's going to make a difference to the treatment to the patient. What you look at is going to make a difference. Although we can look at the whole DNA of a tumor each time, that doesn't make a lot of sense if it's not going to change treatment. So for like an early breast cancer, that's a very low grade, easy to treat breast cancer, knowing the whole sequence doesn't make a lot of sense because the chance of being cured might be 95% for that patient, just with our current treatments. Having said that, if someone's had a Cdk46 inhibitor and they haven't responded, then we might want to say right away, well, why haven't they responded? Let's sequence the tumor right now to know why hasn't this person responded. So the utility of looking at biomarkers depends on the cancer.
Great, thank you. So Lise, you have another question?
Yeah, the next question, actually, I think you've touched on a lot of it already in this last question. But I'll ask it anyways, because there might be a bit more to add and clarify. So you mentioned earlier in the presentation about, and just now as well, about having a biopsy or recommending to have a biopsy when there's a recurrence in case the cancer has changed from the initial diagnosis. And I know you just touched on that in this answer too. So the question is, would you recommend doing a biopsy at progression of metastases as well? So, you know, like not necessarily just when metastases are diagnosed, but throughout. And I guess, at what interval, you know, is it every progression? And then do METs change in terms of mutations and receptor types?
So I'm going to answer the last question starting. Yes, some cancers change. So there's been studies, Mark Clemens, who's in Ottawa, when he was in Toronto with Eitan Amir, did a very nice study a number of years ago where they looked at biopsying people after they relapsed, and about 15% of estrogen receptor positive cancers become estrogen negative. Some series it's a bit higher, about 20%. So it's not everyone, but some of them. Some cancers are heterogeneous. What does that mean? It means the cancer originally is made up of a few things. So there might be a very few HER2 positive cells that weren't appreciated. But when the cancer relapses, it's the HER2 positive. So again, about 10% might be HER2 positive. So it is worth rebiopsying with the first recurrence to know what you're dealing with. Do you biopsy each time? If someone's behaved as expected, so let's say you've got an ER-positive cancer, you biopsied it, it's ER-positive, it responds for years and years and years to the Cdk46. You already know because you looked at it the first time that it's got a PI3 kinase mutation. You might not bother biopsying it again because it's behaved the way you expected it, and you might just treat with a PI3 kinase. Or if you had a HER2-positive cancer, you biopsy it at recurrence, it's HER2 positive, and somebody responds really well to pertuzumab and trastuzumab, you might not re-biopsy it because it's behaved as expected. But if you've got a cancer that doesn't behave right, so for example, I had a woman a number of years ago now who had a really high risk cancer that was HER2 positive, and she got all the treatment. And when she had her surgery after neoadjuvant treatment, had a lot of cancer left. And the cancer that was left, we looked at again, and some of it was HER2 positive and some of it was triple negative. And then about 6 months later, when she just finished her Herceptin, she progressed with some new nodes and all over the place. And we rebiopsied it, and it was only the triple negative that was there. And I actually put her on as a Atezo, one of the immune therapies was available. I put her on Atezo and chemo. She had 6 cycles of Abraxane. She's still on Atezo 2.5 years later and doing well. And I treated her as a triple negative then because that's what had relapsed. So again, it's around utility. Now I talked to you about circulating tumor DNA. We're hoping that we won't have to keep re-biopsying people because biopsies can be painful, but that over time we'll be able to look for those mutations in circulating tumor DNA. So what the future might look like is somebody gets a re-biopsy maybe at the first diagnosis. And then when they progress other times, just gets a circulating tumor DNA. And we can look at the circulating tumor DNA and say, oh, the cancer now is ER negative, but is expressing PD-L1 or is expressing this or is expressing that. So that's the hope of the future, is that through just blood, we'll be able to do it. Cancers evolve, cancers change. And again, that's what I said earlier, is you might not want to biopsy a cancer too many times at the beginning if it's not going to change your treatment, but you might biopsy it later when it really could change your treatment.
So I have a question in terms of relapsing many years later, especially for ER, as we're discussing, would that tumor most likely change? And for those women who were treated with the surgery and the chemo and the tamoxifen and Femara with all those, drugs, would they now clarify this? Would they now go back on the hormone therapy?
So that's a really good question. So most ER positive cancers stay ER positive. As I said, it's only about 15% that change, and those are usually ones that relapse early, not relapse late. If somebody's had, let's say they're 5 years, they had 2.5 years of tamoxifen and 2.5 years of letrozole, and 15 years later relapses, you could retreat with Femara or tamoxifen or something. You'd probably put someone on Femara and a Cdk46 inhibitor. If somebody is on letrozole and progresses well on letrozole, so they're 4 years out from their diagnosis and their cancer comes back, then you're probably going to change them to something like fulvestrant, a hormone they haven't had, plus a CDK46. So it depends on where it's relapsed and how long and what did they relapse on or not. If I saw somebody a few months ago who had said no to all hormone treatment, and she relapsed about 2 years after her diagnosis. So she never had hormone treatment. So of course I put her on Femara because she'd not had it. So it depends on exposure when it happened. What's also interesting is sometimes you can be surprised. I have a patient who was a nurse with a cancer in a premenopausal cancer in the early 1990s, which was treated with chemotherapy, and she had about a year of tamoxifen, hated it, and quit. And she relapsed about 19 years later with a fluid in her lung and some nodal areas. And we put her on letrozole. She never had hormones really. She had a year or two. We put her on letrozole. By then she was postmenopausal. And she had a really quick response. The fluid in her lung went away. All the lumps on her chest wall started going away. And then we got back, they'd done all this fancy thing, that her fluid was HER2 positive. Was she HER2 positive? So of course I went back to her original tumor, which the Vancouver General Hospital had lost. They don't lose a lot of tumors, but hers they'd lost. So I never knew whether her original tumor was HER2 positive or not. But by the time we got that she was HER2 positive, she had already had a good response to letrozole. That was 7 years ago. She's still on letrozole. She hasn't had any Herceptin yet. She'll get Herceptin when she progresses, but she's still on letrozole and doing well. So, I think sometimes you also have to look at how a tumor is responding.
Right. Now, in terms of CDK starting CDK in combination with the letrozole or one of the hormonal drugs in early stage patients. Where's the thought around that?
So the thought around that, so there have been 4 studies that have been done. One of the studies that have been giving ribociclib, the one I talked about, with hormone therapy in early breast cancer hasn't reported yet. In Vancouver, we participated, and lots of places across Canada participated. We don't know the results of that yet, and we're going to have to wait probably another year to find out results. Another one that we participated in across Canada, and the CCTG participated, and Julie Lemieux from Quebec City was our principal investigator. It gave palbociclib and letrozole to women with early breast cancer. It didn't show a benefit. It didn't show that adding palbociclib helped. Another one where we give palbociclib to people who'd had neoadjuvant chemo and still had disease, which we participated in across Canada, didn't show result. But there was one study, the Monarch E, it's called, so Monarch like the monarch butterfly, E, gave abemaciclib to women who had high-risk cancer. So they either had to have 4 or more nodes positive, so lots of lymph nodes positive, or they had to have a cancer that was very active, that had something called Ki67, this marker that showed a very active, fast-growing cancer. And that study, which was reported about a year ago, showed a benefit for giving the abemaciclib plus hormone treatment. The US approved the combination of abemaciclib plus hormone treatment for high Ki67s, and we're really hoping that that's going to be approved and funded in Canada very soon. It looks like it will be for high Ki67s. Is it going to be funded? Hopefully it'll be funded soon. I have put some people on it through Compassionate. So that's what we're thinking about for those. So for women with an hormone-positive cancer, it's a very high-risk cancer. It's got a real risk of relapsing. Can we do better? Many of these women have already had chemo, they've had radiation, they've had surgery. Now they're going on their hormone therapy, and they're going to take a couple of years, 2 years of abemaciclib too, which causes diarrhea and fatigue and isn't easy to take. But hopefully it's going to be funded and available for women who can tolerate it. And hopefully those women who have previously had high-risk cancer won't relapse. Now, the question you're going to ask is, okay, what's going to happen to one of those women? Can they get a CDK gate if they relapse? We don't know.
Okay. I was going to ask that question. I'm going to give you a question from one of the submitted questions. Alpel's, Piqray. Piqray received a do not reimburse recommendation from CADTH in January. Does this negative recommendation impact patient access to PI3K inhibitors? And is this class of drugs still part of treatment protocols in Canada?
Very good question. A number of oncologists around the country have been extremely disappointed in a number of the decisions by CADTH over the last year, where it appears that they're looking for a very high bar and they're not approving drugs that might be of benefit to persons with breast cancer. And I think the decision on alpelisib was one of those. Health Canada approved it, and then CADTH decided not to. And it's extremely disappointing. With the lack of approval, the compassionate access goes down. So it has totally restricted access, not totally, but majorly restricted access for patients in Canada. CADTH said that, it didn't show a survival benefit, but it's very hard to show a survival benefit in second line. And the results weren't trying to do that. So it's very, very disappointing. It's approved in other countries. It's an expensive drug, so to get access to it without approval is very hard. So I think that there's a few handful of people who can fund it, who have access to it now, but it's really, really decreased it. There has been a study using another PI3 kinase inhibitor, MA40, that's been going on through CCTG, and it's an option for some patients, but we don't have results of that yet. And I think it's one of those things that I feel very bad for patients because we can't access it.
Thank you. Lise, can you take on the next question, please?
Yeah, for sure. Thanks. The next question in the Q&A is in regards to lobular breast cancer. Just wondering if you have any comments on lobular breast cancer and metastases specifically. I guess, is it different in any way than ductal carcinomas that we see more often?
So, ductal carcinoma is about 65% of breast cancers, lobular about 15%. There's a lot of stuff about lobular recurring in a slightly different way, often recurring later, often being a bit sneaky. And lobular is one area where things like early Cdk46 inhibitors hopefully will mean that it's going to be less sneaky and come back less. In terms of response to other treatments, there have been some studies to suggest that overall lobular sometimes don't do as well as invasive ductal, but it's not clear that they don't respond to Cdk46 inhibitors or they don't respond to PI3 kinase inhibitors. The addition of those still do better. So you can have a lobular cancer and it's still going to do better if you add in a CDK than not, or add in a PI3 kinase. The other thing is that, again, this goes to defining the cancers. We know something with somebody with a BRCA mutation and an estrogen positive cancer, they might do less well with CDK inhibitors. So there's these little groups like lobular and that all in all might have a less good outcome overall, but might still do better with the addition of the targeted therapy than not. Lobular cancer is a funny one and we have to learn more about it. Again, some early lobular cancers are very easy to cure. Some advanced lobular cancers can be quite resistant.
Is lobular cancer treated mostly with surgery and nothing else?
No, endocrine therapy. Lobular cancers almost always are estrogen positive. Not always, but almost always. Some people believe they don't respond to chemo. I don't believe that. I think some lobulars do respond to chemo. There are different kinds of lobular. There's a classic lobular, a pleomorphic lobular. There's different kinds. And lobular is one kind where we're really, really looking for new targets. There are some new targets that have been defined, and there are studies going on right now looking at those new targets, but they're not reported yet. So I can't give you brand new news about that. But there's a lot of work going on in lobular.
Great, thanks. So this person has been treated for TNBC. In regards to immunotherapy, she's been told that there is no testing for the markers that indicate suitability for immunotherapy unless the patient is in a clinical trial. Is this the case?
No. Unfortunately, it's not, but this is a rapidly evolving field. So what you were told a year ago or 6 months ago might be different than today. So one of the things is that this is changing. In triple negative breast cancer, early breast cancer, I briefly showed you that keynote study 522 where they showed a benefit in early breast cancer. In that study, it didn't matter whether you were PD-L1 positive or not. So all patients with early triple negative cancers appear to benefit from the addition of immunotherapy. This is different than advanced cancer. So if you've got a recurrent triple negative, it does make a difference, and the markers do make a difference. This is something we're just learning about. That evidence in early cancer just came out last summer that it didn't appear to make a difference. And that's really just, I want to go back one step. I talked about the immune system being complicated. That's just measuring one part of the immune system. It might be that 2 months from now, there'll be a paper that says, well, if you measure that other part of the immune system, it does make a difference. So what I tell you today could be totally wrong in a month. I want to just state that. But right now, there are markers that make a difference for first-line advanced cancer. And those markers is something called the CPS score. And the CPS score really measures whether people are going to respond to the drug pembro. So that makes a difference. But it doesn't seem to make a difference for early breast cancer.
Okay. So based on what you just answered there, so how does one keep up with all the changes?
Well, you hope your oncologist keeps up. I think it's really hard, and I think sifting through information is hard. It's particularly hard because there'll be a big headline saying something works, and then if you read through it, it was 4 mice were treated, and 4 mice did well. And so, cancer treatments make headlines, and you sometimes have to sift through. What I've tried to present today are what we call phase 3 trials. Phase 3 trials are the highest level, where they're compared to standard treatment. So those placebos are given because it's standard treatment plus a placebo versus the new drug sometimes. And it's with phase 3 trials that we really get to that place where we can say this is better or worse. and then you can sift through the data and say this is better. A lot of early things, it's hard. When I talked about that new drug T-DXd, I showed you that waterfall plot. We were all really excited about it, but we all stood back and said, whoa, 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 this is only early data. Let's see what the later data really shows. And when I get off this call, what I'm about to do is to submit to CADIF a recommendation that we're all doing today to fund T-DXd, because we all think it's exciting, but we're only going to fund it now that we've had that phase 3 data showing that it's better than TDM1. So, I think it's hard to sift through the data.
Yeah, it is. Elise, go ahead.
Okay, the next question is kind of a two-part question. So the first part of it is in situations of resistance to Cdk inhibitors for metastatic cancer, what are the next lines of treatments that could be available? And then, so specifically Cdk inhibitors. And then the second part of the question is are there any clinical trials underway to better understand resistance and find appropriate treatments?
So the usual next treatment after CDK4/6 would be if somebody had a PI3 kinase, alpelisib plus fulvestrant. Again, we talked about the problems of accessing alpelisib right now. There are other drugs. I see they put in FGFR inhibitors and things like that. There are other drugs. ESR mutations, as I talked about, suggest resistance, but they're not enough of a reason to change right now. There are cousins of fulvestrant. Fulvestrant is something called a SERD, S-E-R-D, so a SERD. And there are new SERDs coming along that are oral drugs. Fulvestrant is an IM injection. Some of those new oral SERDs look really exciting. And there are other drugs that are being combined. So in terms of trials, there are lots and lots and lots of trials going on looking at these resistance. Because estrogen receptor positive cancers are 70% of cancers, there's a lot of work going on. As well as CDK4/6, there's something called CDK7, and there's a new drug CDK7 that looks exciting. But again, it's only an early trial. We have to get a later trial. There's CDK2 that looks exciting. So there's a lot of stuff out there, but if right now to say to somebody, this is their best treatment, I don't know. With all of the trials, they're taking blood to look for circulating tumor DNA. They're often biopsying tumors. And why are they doing that? They're trying to figure out why some cancers respond and why some cancers are resistant, to understand better who should be treated and who shouldn't. At this point of time, there's no one answer. But that's sort of the holy grail. The holy grail is to figure out what to do after CDK4/6 inhibitors.
Do we have more questions, Jen? I know we do. Which one should we?
We do. Can you hear me?
Yeah.
Okay, you just can't see me. That's all right. So another question's coming in. If you progress on Palbo, does that mean that ribociclib or Verzenio abemaciclib won't work either?
So there's a good question. So ribociclib and palbociclib are pretty similar, but not exactly the same. When we talk about CDK4/6, it means it hits both 4 and 6. And palbo hits a bit more 6, and ribo and abema hit a bit more 4. So there might be a bit of a difference. There's an older study that gave abemaciclib after palbo and showed some response. And some people think that abemaciclib as a single agent after palbo or ribo is good. There's not a lot of data yet. But certainly, I think it's an option. I think it's certainly an option for progression after palbo to consider abemaciclib.
Okay. So what about lobular metastatic breast cancer that has lost hormone receptors? That's the question that I have here.
So that would be treated with chemo. So we ought to avoid chemo, obviously. But chemo is often effective in those. And, the first chemo that many doctors would do is capecitabine, because it's an oral drug that's often very well tolerated, doesn't cause hair loss, can be given chronically for a long time. Other chemos are effective. And this is where learning more about the tumor and finding out what's driving it could be important. And this is where the future of precision medicine is. But chemo might be very effective in that situation.
Right.
And if it's become triple negative, then the chemos like Trodelvy might be effective, or those kinds.
Okay, great, thanks. Well, those were a lot of questions. That was an excellent presentation, and I thought we did a wonderful job, and I'm sure that we've covered a lot of ground for our listeners. And I want to thank you again so much. Thank you, Lise, for co-hosting. That was fantastic. And I want to thank everyone for submitting excellent questions and for joining us. And thank you for sharing your insights again, Dr. Gelmon. And I also want to remember to thank our sponsors, Viatris, Novartis, Merck, AstraZeneca, and Pfizer, who made this possible. So I look forward to connecting with everyone on our next virtual session. And I wish everyone an excellent day and enjoy your day. Thank you, everyone.
Thank you very much.
Thank you, Kathy. Thanks, Dr. Gelman.